Hello, good afternoon, everyone. Today, we are here with yet another session of Indian Fertility Societies Vibrate. So, for today's session, we are having Dr. Bharti Dore Patil with us. She is a DNB, DGO, FICS, FICOG, VF Consultant Nova IVF Fertility Pune, Head of Gynecology Department Shri Hospital Pune, Vice President IFS, National Vice President Foxy India 2016, Past President POGS, Past President IMA Pune, ex-chairperson Clinical Research Committee Foxy, National Corresponding Editor, Indian OBGYN Journal, Founder Executive Member, Gynec Endocrine Society India, Founder Chapter Secretary, West Maharashtra Chapter IFS, Executive Editor, Journal FSR, Foxy Star Awardee 2016. So today, Dr. Dhore Patel will be throwing some light on the topic common errors in infertility practice management and how to tackle it. So, Dr. Dhore Patel, over to you.
Thank you very much, Tejas. At the outset, I would like to thank Indian Fertility Society for this invitation, and which is a very unique program, Vibrate, and it has been connected through DocMode. So we would like to thank DocMode for that, and in special Dr. Sudha Prasad and Dr. Neena Malhotra from the IFS, and this is a very close to my heart, the topic common errors in infertility practice. How can we manage them? Accurate detection of underlying reproductive abnormality is the actually management decisions, and it will maximize your treatment outcome. Clinical evaluation of any infertile couple may be grouped into 4 categories. Semen analysis, very important. Assessment of ovulation, uterine or tubal evaluation by HSG or sonography 3D, and ovarian reserve assessment is the main key factors, 4 factors which you have to see into the patient, and that is a basic initial patient's workup. So let's go by clinical situation one by one, and we'll see where and how we are doing the common errors and how can we tackle them. So that is going to give you a practice points when you sit for your patient's management, and will give you a perfect guideline how can you proceed and give the maximum pregnancy rate for the patient. So first case, Mrs. A, 24 years, 2 years married life, primary infertility, and a no history of contraception used. Cycles are irregular. Length of the cycle 30 to 45 days. Duration is 4 to 5 days. Normal flow. Coital history, regular intercourse. Look at the female partner, evaluation is been done, cycle is irregular, so sonography was been done, the bilateral ovaries are showing polycystic ovarian morphology, and her hormonal profile shows FSH on day 2 and day 3, FSH 6.39, LH 4.27, prolactin 13.16, TSH 2.58, and AMH is 5.67. So your diagnosis immediately starts clicking in your mind. You see the tubal factor by hysterosalpingography, or you can do saline sonography. Bilateral tubes are normal in her case. Bilateral spill plus uterine cavity shows normal. A male partner evaluation is been done usually by semen analysis, looking at all the parameters. Physical characteristics shows viscosity plus and a liquefaction time 40 minutes. Count 130 millions, total motility 85%, progressive 75%, and morphology 40% normal. That means it's a normozoospermia. So the patient was very easily, you all know that we plan the patient when the tubes are fine, the semen analysis okay. And the patient is been diagnosed as a PCOS, that is polycystic ovarian syndrome. The first line of action, it goes COH with IUI for 3 cycles, that is control ovarian hyperstimulation with IUI for 3 cycles. This patient was been done the first cycle of IUI, and this is her follicular monitoring report which came to us, and we were seeing this. On day 3, there was no cyst. Both this is a basic scan which was been done for the cyst documentation. no cyst, and the endometrium was thin. The day 8 patient was been called again for the follicular monitoring, and which is showing no follicles on both sides. Day 10 the patient comes again back, and then again it shows that there are no follicles on both sides. And 16th day again no follicle, no dominant follicle, no growing follicle. And 19th day again the same situation. If there's nothing is been happening in the ovary, no follicular growth was been seen, in spite of giving letrozole 2.5 milligram for 5 days, cycle was abandoned. Throughout her endometrium was 5 millimeter endometrium. This was the unique feature in this cycle, first cycle. Now, how do we proceed in these patients? If the patient comes like this with letrozole not responding, that means she is a resistant PCO patient. The second cycle was been taken, and we thought that PCO patient is a high threshold patient. So we increased the dose. Patient was not ready for gonadotropin, so we increased the dose of letrozole and we took the step up protocol. 2.5 milligram on day 3, 2.5 milligram plus 2 tablets, that's 5 milligram, 7.5 milligram on third day, and the fourth day, day 5 was 2.5 milligram, 4 tablets, that is step up protocol. You go up to 10 milligram. So we increase the dose, the threshold would be catch up with the PCO patient. This is her follicular monitoring. Day 3, again the scan shows no cyst on the both side. Endometrium is thin. Day 7, the patient was been called. On the right side, she had 13.7, and left side there was no follicular growth. Small follicles were there. Multiple small follicles were there. Endometrium was 5.4 millimeter. Day 10, 14.5 millimeter right ovary follicle was there, no multiple small follicles on the left side. 6.5 millimeter was the endometrium. Day 14, the follicle grown up to 18 millimeter. That means we worked. It worked. The letro step up protocol worked. So that itself suggests that the patient had a high threshold, and we needed little higher dose for this patient. So 18 millimeter follicle was there, 6.6 endometrium. Endometrium was still not very good. It was not crossed 7 millimeter. And the blood flow was still zone 1, but still the trigger was being given because the follicle was okay. The doctor thought that time this was a right time. The trigger was given. IUI was being done on the 16th day. Luteal support was given, tablet dydrogesterone 10 milligram 3 times a day for 15 days, but still the UPT came negative. Now, this is a usual scenario which happens in day-to-day practice. We get stuck here because what to do next? So, what do you think common errors you have done in these patients, or what was not been looked at this patient? So before starting the third cycle, we must understand retrospectively where we have gone wrong. What are the common errors which we have done in these patients? So let's see one by one. If you look at semen analysis, in the interpretation, it is viscosity is high, and plus the liquefaction is 40 minutes. So when you do IUI and you know that viscosity is very high, your embryologist will start syringing the semen to liquefy. The syringing will make reactive oxygen species higher and free radicals more, that will hamper your pregnancy rate. So probably in this patient, you should have been given a pre-medicated or container containing the media, which will give a liquefaction time earlier. PCO patient is not been categorized whether she is a hypoestrogenic patient or she is a hyperestrogenic patient. What is her antral follicle count and what is the phenotype which you are looking at? If you are looking at different phenotypes, you will understand some patients will best get treated with clomiphene citrate, some patients will get best treated with the gonadotropin, and some patients will get best ovulation protocol outcome by giving gonadotropin. So, depending on whether the patient is a hypoestrogenic, that means her FSH, if you don't do the E2 level, you can do the FSH level, and depending on the FSH level, you can start understanding whether this patient is a hypoestrogenic or hyperestrogenic. Or broadly, you can see the patient, if it is a thin patient, it is usually is a hypoestrogenic patient. And when the patient is a obese patient, it's a hyperestrogenic patient. You can categorize like that also. It was been given the same protocol in spite of the endometrium problem. We were all looking at the follicle should grow, and because the threshold was very high and we were concentrating on the threshold, the same protocol was being given in spite of the endometrium problem. If the endometrium is not more than 7 millimeter, probably your IUI may not work. What was the luteal support given? Was it a sufficient luteal support, or something else should have been thought? What next? We should not be thinking of laparoscopic ovarian drilling in these patients. Look at her AMH level. AMH was 5.6. So this patient, if you do the laparoscopic ovarian drilling, she will go into premature ovarian insufficiency. So big no for laparoscopic ovarian drilling. Say what to do next. Look at the menstrual cycle pattern. Maybe the pattern should be seen whether it is regularly irregular or irregularly irregular. Depending on that, you will understand how much, how many gonadotropins to be given to this patient. And then look at the high hormonal profile. If suppose your FSH is more than 5, that patient is a hypoestrogenic patient. Uh, because when there are low estrogen, the FSH will naturally rise. So when you see more than 5 FSH, it is usually a hypoestrogenic patient. And look at her AMH 5.6. Never drill the ovary which is less than 6 nanogram per ml. So this is a very good cutoff. You should keep understand and don't drill this type of a PCO patient. PCOS patient, if she crosses 3.5 nanogram per ml AMH, that means she is likely to get hyperstimulation and she is a patient of PCOS. But 3.5 to 6 should not be drilled at all, because these patients can be very easily tackled with the medicine, or you can stimulate this patient. If it is more than 10, still laparoscopic ovarian drilling will not work in this patient, because too high AMH will have a too high androgen, and only 4 punctures, 40 bats will not be sufficient for those patients and they will not respond. So the best category of the patient who can go for laparoscopic ovarian drilling is between 6 to 8 nanogram per ml. So what is the choice? Letrozole or gonadotropin is the right choice for this patient, or do you want the combination to be given, or do you want gonadotropins to be given for this patient? You should try and understand and then analyze the patient and start the management. Is optimization required in this patient? Because this is a PCO patient. She is high insulin resistance. That is very common. 50 to 60% of the patient have an insulin resistance. Do we have to optimize this patient by giving insulin sensitizers? We have to look at it. What could be your plan of action for the third IUI cycle? So design the protocol. Then and then only you will understand to get the good results. So letrozole may not be ideal for this patient. So we take it out that letrozole. Rather, should be given gonadotropins to start with, because letrozole will not work in the patient who is hypoestrogenic. Letrozole drastically reduces your estrogen, and if she is already hypoestrogenic, probably her endometrium will not work, and that will not give you a good pregnancy outcome. So gonadotropins is the best choice now for this patient. So which type of the protocol you will use for this patient? Either conventional or the low dose step up protocol. Conventional protocol, you can say on day 2, day 3, day 4 and day 5 you give the gonadotropins. Then day 5 you do the sonography, and depending on her uh, stimulation over follicle size, you either increase the dose or decrease the dose. That is a conventional protocol. Low dose step up protocol, you will start with a very small dose, maybe 37.5 or maybe 75 units, and then slowly go up as the endometrium grows and the follicle grows. Optimize these patients with insulin sensitizing agents. Then IUI semen collection should be done with pre-media container. That is very important. And luteal support, if you can, when she is a hypoestrogenic patient, if you can add the estrogen, depending on the follicle number, if you add the estrogen, probably that will give a good luteal support. So what we plan for this patient, we started myoinositol this patient because she was not compatible with the glycomate or the metformin. We started her gonadotrophin 75 units FSH every day from day 3. And day 7, we saw that she had 3 follicles, 14, 13, and 13.5 millimeter. Day 10, we could see that 18, 19, and 19.5 millimeter follicles. That is a good response. And the endometrium was 7.8 triple line. That was also a good response, although it was not to our expectation, like we were expecting her to cross 8 millimeter. But then 7.8 is also good. Triple line it was. Trigger was been given HCG 10,000 units, fulfilling all the criterias of the blood flow indices. That is, peripheral blood flow was 70%, PSA was more than 15, RI was less than 0.5, and the trigger was given to this patient for that particular cycle. So these are the different criteria we see when we give HCG. We see follicle, we see triple line endometrium, we see follicular or endometrial halo, cumulus presence, follicular volume, flow indices, especially peak systolic velocity, PSV and RI, perifollicular vascularity we see, and we always see, also see the subendometrial vascularity, and we see the endometrial peristalsis. We can again see uterine artery also. Out of these 10 criteria, even if suppose she meets with 5 or 6 criteria, I think that's the day when you have to give the HCG. So let's go one by one by example, like how can we decide depending on the flow parameters. Like day 10 patient comes, your dominant follicle is 18 to 19 and your endometrium is 7.8 millimeter triple line. Now, in these patients, we are in dilemma to be given HCG or not to be given because endometrium is 7.8 millimeter. Do we have to wait for a day and allow the follicle to go to 20 millimeter and endometrium to 8 millimeter? But the blood flow indices will give you the guideline. If her blood flow indices says that PSV, that is peak systolic velocity, is more than 15, 85% of good flow, and her resistance index is less than 0.5, this is the right time. Give HCG for this patient because this is the sign of impending LS surge. So probably this will give the guideline that how can we go and give her a HCG trigger. So if you look at this PSV, if the peak systolic velocity is good, her resistance index is less, then that means this follicle is waiting to get ruptured. So give HCG right away. We gave her, IUI was been done with pre-treated semen with proper technique, and luteal support was given with estrogen and a progesterone. 15 days you can give progesterone vaginally or orally, doesn't make any difference, but you can start progesterone immediately after your IUI. And after 15 days we could see that her pregnancy test was positive. So thank God, this is the way we started looking at the patient and we achieved the pregnancy outcome for this patient. So we must try and understand when we do the ovulation induction protocol, our magic wheel had to slow down. We should try and understand how many follicles we want and how many follicles to be going for the dominant phase and how do we optimize the pregnancy rate. So individualize the ovarian stimulation protocol for any PCOS. Don't put all the PCOS in one basket, categorize them phenotypically, and thus you will get the better pregnancy rate in different PCOS. Influence of your control ovarian hyperstimulation can be on oocyte as well as embryo quality. So less is always more in these patients. So look at these 4 types. These are the 4 parameters. Polycystic ovarian morphology on sonography. All of them are PCO patient, but if you look at them, all will act very differently or behave very differently. The best category will be here when the AMH is just above 3.5 She is a ovulatory PCOS and she is very likely to get stimulated and very easy to get pregnancy, but very easy to get aborted also or early pregnancy loss. So always look at the background hyperandrogenism in this patient, optimize this patient and start the insulin sensitizer, continue to, till 12 weeks, that will go ahead a good pregnancy outcome. If you look at this two PCOS patient, this patient will be very easily get stimulated, very less trauma, and the follicle size is 6 to 8 millimeter. So once the follicle size is 6 to 8 millimeter, very easily she will require a very low dose, and then once they go, she is likely to go for hyperstimulation. Very less chance of a pregnancy outcome in this type of patient. So optimization is very important in this patient also. In this patient, looking at this, ovary is very stubborn. This is a resistant ovary, very high stroma. If you look at the stroma, if you look at the blood flow, it will be high blood flow and very, very difficult to stimulate this patient. If suppose you stimulate, this patient grows very well, the follicle will grow very well and very good pregnancy outcome will be there. So catch is that you have to catch her threshold. If you cross the threshold, you will get a good ovulation induction in this patient. Now, this patient is also PCO patient, but this is 35 years old patient. And that's why you see her follicles are discrete. Now they are different places, but look at her stroma. It's a very thick stroma. Now, this type of a patient has to be dealt very differently when they cross 35. Probably IVF will be the first choice for this type of a patient. So this is the first scenario, first case scenario. We go to now second scenario. Uh, Anybody has questions, they can put on the chat. We will, after the end of the session, after the end of the lecture, we can try and give the answers as many as possible. So please write it down your questions on the chat box and we will answer them. Coming to case number 2, 30 years old patient with secondary infertility, 2 years, past history of right side ectopic pregnancy, self-injectomy was been done laparoscopically. HSG was been done after that. The left tube shows it is a patent. Ovulation induction study was been done 10 times. Now you will wonder why 10 times? Whenever you write it down, secondary infertility, everybody starts taking everything lightly and we think that she is already a fertile woman. And that's how we start going ahead with ovulation studies one by one, and 10 times. Ovulation was been there mostly on the left side with timely intercourse. So this should have been got a very big tick mark in your mind. How on the earth she has all the time ovulated on the left side? Ovulation induction was been done 6 times with tablet letrozole. The dose was same, 2.5 milligram for 5 days. Then 2 times clomiphene citrate and 2 times there was no drug. So this is the scenario which was been done by a gynecologist, and it is very likely that everybody, almost 50-60% of the people or gynecologists does the same. All ovulation inductions are given luteal support for 15 days and still she had no pregnancy. Semen parameters, it was 6 ml volume was been given, 45 minutes liquefaction time, 60 millions per ml, 40% motility, progressive motility, 10% abnormal morphology. This scenario, nobody has looked at his volume. 6 ml volume is a very high volume. And liquefaction 45 minutes, that means it's a viscous sample. Patient is referred directly for IUI to us after giving HCG by a local gynecologist. So what do you think that common errors has been happened in this case? So let's go one by one. Hormonal parameters was not been done at all in this patient. She was not knowing how much AMH she has, what is her FSH level, what is her LH level. Nothing was been done on no TSH, no prolactin. In spite of thin endometrium on 2 cycles to 3-4 occasions, CC was been given the 4th cycle. So you know all clomiphene citrate will have a estrogen side effects, and then Thus, it will give a thin endometrium. So, we should jump from CC to lactose. It has been lactose to CC. In fact, even though there was a thin endometrium, follicular monitoring was not corresponding with the endocrinology of the patient at all. That I will show you with the case reports. Ovarian reserve analysis was not been done for this patient, and they were not looked at 6 ml volume and a high viscous sample, and they had done 10 cycles of timely intercourse. Now, these are the studies. These look at the follicular studies. If you very carefully see the first study, the patient starts the follicular study from ninth day, and she's been written here MSF. Just note down, I will tell you what the report is all ultimately when we saw. And here it has been seen that the follicle is grown and 19 millimeter is gone, 8.3 millimeter, and free fluid plus is there. So this was the first follicular monitoring, which was being done with the letrozole 2.5 milligram. Now coming to the second, again she started from 11th day 9 millimeter on the right side, and then started on the ninth day, and here it was been done for till 14th day, and the follicle was grown and ruptured. 7.1 millimeter endometrium was there. Now again, this is the scenario: 10 millimeter, day 10, day 9 it is started, and the follicle was ruptured on the 11th day. Then one last sonography was being, one side, right side was somewhere 12 millimeter and ekdam 16 millimeter, and that was continuously 16 millimeter. And day 23rd, she had ovulated. Now, her cycle length is only 28 days, and she is ovulating on 23rd. And if you do IUI on 25th day, hardly there are 3 days she is going to bleed again. So, again, a thin endometrium progyno was been given over here. If you see here again, the follicle MSF is written on this side, and in spite of thin endometrium, clomiphene citrate was been given on the last cycle. So nobody, not a single gynecologist or that gynecologist thought of starting the gonadotrophic. So we did her sonography, and then this was our findings. Uterus was retroverted, retroflexed, normal size, with small two fibroids in the posterior wall. Endometrium was very thin but trilaminar, and right ovary, this is on the day of IUI because patient had been sent directly for IUI. So endometrium was just hardly 6.8 millimeter, but trilaminar definitely. Right ovary showed very small, almost not seen. The ovary was totally not seen, and she had undergone the sulfingectomy on the right side. So I don't see any antral follicle count, AFC, on the right side. Left ovary was again small, and out of that, two to three only antral follicles were seen, and the dominant follicle was collapsed. Pouch of Douglas was normal, and we inquisitively did her AMH test on that day itself, and we had the report in our hand, zero point 0.7 nanogram per ml. So this was the follicular study. Looking at the ovary itself, you should start judging. See, your whole ovary is like a dominant, is the size of a dominant follicle. So look at this ovary. It's a whole ovary was like a dominant follicle. So in this scenario, the left right ovary was been not seen at all anywhere. And the endometrium was trilaminar, thin endometrium. So follicular study is very, very important, and sonography is all the more important in these patients. So in this scenario, we diagnosed her as a premature ovarian insufficiency, and this patient, if at all they have to go ahead for the baby, they should go for IVFC rather than wasting their time in IUI. And that patient is now likely to go into IVF in the next month. We will let you know. We will have 2 or 3 follicles, or maximum 4 follicles, not more than that. But as her endometrium is very good and she has a secondary infertility, she probably will get into a good pregnancy outcome. Coming to third scenario, Mrs. X, 23 years, married like 2 years, primary infertility, never used any contraception, BMI 20, cycles regular, vital history normal, female, she is ovulatory, menses regular, FSH 7.2, 5.4 LH, 50.8 nanogram prolactin, 1.6 TSH, and 2.8 AMH. So, looking at overall, you know that this is a catch point, this is a hyperprolactinemia. When she crosses 20 or 25 nanogram, this patient should be ideally diagnosed as a hyperprolactinemia and start treating the patient. Patient was being treated. Sonographically, uterus normal size, one side ovary was 8 and 9 AFC, both side, uterine cavity normal on HSG, both tubes were okay, bilateral spill could be seen. Evaluation of male factor, we could see that the patient had absence of sperm, that is azoospermia. Now, what will you do in the patients of azoospermia? The moment you see the azoospermia report, you should not be immediately disclosing those reports. Rather, you should do two occasions and then tell the patient about the azoospermic status. Or you centrifuge the sample and then only you label the patient as azoospermia. Semen analysis to be repeated after 15 days or maybe 7 days with specially centrifuging the sample that will give you a correct diagnosis, and accordingly you give the patient label as a azoospermia. Now, whenever a patient of azoospermia comes, first think of hormonal profile to be done for that male. FSH, LH, serum testosterone, serum prolactin, and TSH should be ideally done to identify which category this azoospermia fits into. That patient's FSH was 37, LH was 18, serum testosterone 157, prolactin 15.9, and TSH was 0.9. So this, looking at the hormonal profile, we know that it is a hypergonadotrophic hypogonadism. So gonadotrophins are high, the gonads are small, and that's why you don't get the sperms. Scrotal sonography was being done. Bilateral testes were small in size and volume. Epididymis was normal, vas deferens normal, and we could see that pampiniferous veins on both sides, no reflux on the valsalva. So it was non-obstructive azoospermia. When the epididymis is normal and the testes are small, it is the totally no obstruction at all. So it is non-obstructive azoospermia. So whenever there is a non-obstructive azoospermia, now you have to do the TISA or TESE. And in these patients, you must know what is the deletion in this patient. That is called Y microsome. The microdeletion has to be tested, because depending on the region, which region is been deleted, you will come to know that whether we can still find the sperms in these patients even if there is a high FSH level. So AZF, A, B, and C regions to be tested in the Y micro deletion testing. If suppose she finds to be AZF A deletion is there, AZF B deletion is there, or AZF C deletion is there, depending on that, you will know how you can predict the TISA success rate. If it is AZFC, 50% chance is there that you may get the sperms in this patient, and the frequency of the deletion would be 5% will be AZFA, 10% B and C. So majority of the azoospermia patient or severe OAT patient will have AZFC region to be open, and you will get chances of 50% sperm retrieval. And this will give a counseling to the couple that this they may go for IVF ICSI in these patients and may likely get the sperms of their own, and they may get the pregnancy outcome. So these are the pros and cons. We tell the patient what can happen if suppose we give the testicular biopsy, or if we don't do the trial essay and do the IVF ICSI, how the chances of IVF is there. The patient opted donor IUI. They didn't wanted a TISA, and they wanted opted donor IUI. So once the patient is opted donor IUI, now how will you stimulate this patient, or how will you plan her actions or the treatment management? Female partner again evaluate young patient, ovulatory cycles, normal tubal factor, normal hormonal profile after taking the cabergoline, that is zero point 0.5 milligram once a week for 4 weeks. So hyperprolactinemia was treated. In these patients, how will you stimulate these patients, and how will you proceed in this scenario? So patients, my residents started, my fellows, they started IUI with letrozole. So we see the first line of management, letrozole. Three to seven, day 3 to day 7 was given. Dominant follicle was 12 to 20 millimeter. 12th day, 20 millimeter trigger was given. As usual, phenotype matched cryopreserved sample and IUI was done. Luteal support was given with micronized progesterone 200 milligram daily, and patient was being come back on 15th day UPT negative. Now this is not done. We don't like this. When patient is given IUI donor, which is a good donor, and she is absolutely young patient, probably somewhere something is going wrong. There are common errors which can happen in these patients also. We must try and get the good pregnancy outcome. So ovulatory patient, probably no need of stimulation. We should simply go and look at her ovulation when it happens. Letrozole is effective in CC resistant PCO patient, not the patient who is the ovulatory patient. Probably you will suppress her estrogen and her endometrium will not be receptive. Probably she may not require luteal support altogether if you go naturally to this patient. So we planned second IUI cycle, natural cycle, maybe gonadotrophins. If at all you want to increase the pregnancy rate, like natural cycle will give you 10% to 15%, and gonadotrophins will add another 10%. We tried natural because the patient was young and she didn't wanted a multiple pregnancy at all. So gonadotropin was out of question. Day 8 follicular monitoring was done. 15.5 millimeter follicle was there. Endometrium 7. Day 10 17.5. Day 11 18.5. 7.5 millimeter. Blood flow indices was still not matching, and that's how we waited for one more day. And day 12, 19.5 millimeter endometrium follicle, endometrium 7.8 millimeter parameter improved. So we gave her day 13, 20 millimeter follicle, 8 millimeter endometrium, blood flow indices improved, and I think we gave the HCG injection at that time because there was a peripheral blood flow 70%, PS with 12, and RI was less than zero point 0.4. So IUI was been done with good parameters, 24 hours and 48 hours. This was because it was donor, we thought of twice. No luteal support was been given. Serum progesterone was done on day 9. This was very specially a different step we took because we had not given her luteal support. We wanted day 9. How is she responding to our stimulation protocol, our IUI, or in the natural cycle, and we found that her serum progesterone was 9 nanogram per ml. The moment we find her serum progesterone 9 gram, we supported her with micronized progesterone 200 milligram 2 times a day for next 8 days. UPT was done on 15th day, and we saw that UPT was positive. We continued her support till the FSH heartbeats were positive, and good pregnancy follow-up was being done for this patient, and she had a very good, healthy baby. So these are the different scenarios. I think we have been 3:40. Tejas, we have time. Hello,
Yes, ma'am, we do
Tejas.
have time. Yes, we do have time.
One cycle, one case we can do. So case number 4, Mrs. X again, age 24, married 3 years, primary infertility. She never used any contraception, BMI 22, cycles were regular, fertile history normal. Male, female parameters, she was regular cycles, ovulatory, ovulation on 14th day. Her FSH was 4.2, LH was 2.4, prolactin 21.8, TSH 1.6, and AMH was 2.07. Probably everything seems to be absolutely fine for this patient. And here is actually the catch. Whenever you find this everything is from normal, we tend to tell the patient, look, everything is fine now, you go back and just try. But before asking her to go back, just do her sonography very clearly. Clearly, you will find somewhere the clue. So in her case, uterus was normal size, antiverted, endometrium was good, but right ovary was showing the endometriotic cyst, which was very small, 2 by 1.5 centimeter, very very small. It was, but there was endometriotic cyst. Left ovary was normal, uterine HSG was uterine cavity normal with bilateral spill equally, and her male parameter was almost normosospermic. No any treatment was being taken by of this patient. Now, what to do in this patient? Now, you are finding endometrioma, which is less than 3 centimeters. She's ovulatory patient, patent tubes, no obvious pelvic anatomy distorted, young age, married for 3 years, normal male factor, and less than 4 centimeter or 3 centimeter endometriotic cyst. How can we go ahead? We planned for 2 cycles of IUI with controlled ovarian hyperstimulation. Why we did like this is the ISHRI guideline. We take the support of the evidence. They say down regulation with OCP did not improve. Medical suppressive treatment is not good for the fertility. So planning of IUI is very good. And super ovulation will increase the chance of pregnancy as the number of eggs increases for the sperms to fertilize. So rationale behind the ovulation induction in IUI, especially in endometriosis, where endometrioma, which is less than 3 centimeters, is justified. So we stimulated this patient with clomiphene citrate 100 milligram. There was no point in starting aromatase inhibitor. So started with 100 milligram, 2 to 6 days, and then HMG was been given on day 4, day 6, and day 8. That means combination protocol. Follicular monitoring was been done. Day 12, we had two follicles, 19 and 19.5 millimeter. Trigger was given HCG after the blood parameters met with. IUI was done on the 14th day with ET was 9.9 millimeter. Semen preparation was been done with swim up. 50 millions, 100% motility. Luteal support was given with micronized progesterone, again 200 milligram twice a day vaginally to this patient. Unfortunately, UPT came negative. Now, what can be the reason for failure? We must start thinking and asking the questions. And what should be the next plan of action for the next cycle for this patient? So, reason for failure of IUI could be one, because she had endometriosis, poor oocyte quality, sperm inactivation, increased DNA damage of the sperms, oocyte, and embryo, decreases the fertilization, low grade embryo formation, and reduced implantation. These all could be reason, and plus there could be reason that inflammation at peritoneal and follicular level. As soon as the egg gets releases, TNF alpha factor is high, cytokine is high, and it starts recognizing this own oocyte is a foreign oocyte, and it starts getting inside and doesn't allow it to go to the tube. So second cycle was being stimulated because the clomiphene citrate was not work last time. We completely changed and we thought letrozole with FSH could be the best choice for her. And the same scenario, luteal phase was being totally changed. We did not give a micronized progesterone, but this time we say immunomodulatory dydrogesterone, especially in endometriosis, works very well. So 10 milligram 3 times a day daily was been given in this patient. Still, the UPT was negative. This was a dilemma. Now, what to do? What is the cause of failure? Maybe rupture was not very good, ovulation was not happened. Maybe poor fertilization or poor embryo quality or poor in peritoneal environment altogether. So, those all could be the reason of failure. So, we thought, why not to have the role of laparoscopy after two failed good IUI cycles? So patient was posted for operative hysterolaparoscopy. ASRM revised classification of endometriosis was done when we went inside. It was grade 1 mild to moderate endometriosis was been seen. Adhesolysis done with fulguration of endometriotic spots. Small endometrium was removed. Bilateral tubal spill was been seen. Post-operatively, injection leupride depot was given, 3.75 milligram was given to this patient. And in the view of mild to moderate endometriosis, young age, good ovarian reserve, removal of inflammatory focus, patient was down-regulated. We immediately planned her IUI within less than 3 months of her surgery with gonadotropins directly, no ovulation orally inducing agent at all. Started with HMG 150 milligram daily. Follicular monitoring was been done. Three follicles could go ahead. Trigger was been given, but trigger now was been given differently. It was recombinant HCG 250 milligram was given. Nowadays we give a dual trigger for this type of patients, especially endometriosis, because endometriosis follicle sometimes does not get ovulated unless you have a very good trigger. So we nowadays give GnRH agonist 2 milligram along with recombinant HCG 250 milligram. IUI was done on day 14 and luteal support was given dydrogesterone, but this time we did not give 10 milligram 3 times a day, but 20 milligram 3 times a day. So it was a higher dose because it was endometriosis, and that to mild to moderate endometriosis, we increased the dose of dydrogesterone, and this has been evidence based. It has been justified in few of the clinical studies. So we thought maybe we will increase the dose 20 milligram 3 times a day, and this patient was pregnancy test positive. So this is how we have to start looking at each patient till they become pregnant, or you finalize their journey till the IVF cycle, or if you are doing the cycle, you should justify in doing the IVF cycles to these patients till they become pregnant. So infertility treatment is not one line, one track management. It is always has many roads reaching to the destination. So there are many factors involved, many treatment options are there. So problem is only we do not think, we do not audit our patients' previous cycles. If we start auditing and if we start noting down what common errors we have done in these patients, slowly you reach to to one point, then you automatically starts understanding what errors we have done, and then you rectify in the next cycle. So this is how you start making the diagnosis of your errors, or anybody else has been done those errors, rectify them, protocol them properly, design their protocol, and then get them stimulated and get the pregnancy outcome, a good outcome for, or optimize their pregnancy outcome in their time duration, because infertility is again a race with time. Infertility management is a race with time. Time is a very crucial factor. Women's age is very important, and duration of married life is very important. If it crosses 3 years, start, it must take your mind why this is happening. 3 years is a pretty long time to conceive, so something is going wrong somewhere. When it's 3 to 5 years, you must be active management of infertility. When it crosses 5 years of married life, you must have aggressive management of infertility. And if it crosses more than 7 years, your last options has to be opted to the patient, or at least explain the patient. If you are not doing, at least they should know this is the door, these are the doors which are open for her, and she has to take them if she wishes. So, like this, you see the woman's age, 30 years, start ticking, immediately start looking at her ovarian reserve. The duration of infertility is very important, like if it is 3 years, 3 to 5 years, 5 to 7 years, and more than 7 years is very important. And the third factor, how many factors are involved in her history. Like if she has a single factor like azoospermia, one single factor, look at the option, even if you can go for the natural trial and go ahead and do the IUI donor cycle in these patients. If it is a multiple factors, suppose male factor is there, the female factor is there, female has 2 3 factors, probably don't unnecessarily waste the time but go for IVF directly. That will give her the best pregnancy outcome. Thank you very much. Tejas?
Yes, ma'am. We can go on for the question and answer session now.
Yeah. I'll just. Uh, Dr. Rohini Das is asking from Kolkata, errors in cryopreservation of eggs and embryos. Can you explain some medical errors leading to gamete uh, or embryos being just a minute, I'm not able to see a full question. Embryos being lost or degraded. This can happen, but this is a totally a good experience. Embryologists would not lose the eggs or the embryos because they have been used to doing this all. And if it is not been validated, embryologist, see, validation of the embryologist is very important. So you must know whether the embryologist is experienced in handling the gametes. Otherwise, they are going to lose, and this is a very very uh, big mistake which can happen in the laboratory by losing the eggs and the embryos. So second question comes from Mohan Surti from Mumbai. Um, he's again saying the same. I think how the gametes are being lost or degraded. This is all actually embryologist purview. There should be a best good embryologist, and this all medical errors should not be done in these patients. The fourth one, Kaleki, she's from Gujarat. Misdirection of gamete or embryos. Now, I really don't know how you've been misdirection in the sense what I'm not able to understand. If you can personally talk to me, I will solve your problem. But misdirection means I did not understand this. Sachin Shah from Pune. Good afternoon, everybody. But he's not written any question. Now, Hussein from Mumbai list out some methods to avoid these errors. So, these errors, as I told you, has to be a good seasoned embryologist which has been trained, and please check the validity, how many years the embryologist has been working in the field, and please take the note from her gynecologist or whichever place she or he is working, and how good is her or his performance there. So this is will solve your errors. Satish Birdekar from Maharashtra. How can we streamline selecting the reception process? I think reception process means probably he wants to say implantation process. We cannot streamline any implantation process because this is molecular level and we don't know. Only we can select the best embryos and maybe blastocyst on day 5 and look at the endometrium. Unless the endometrium is triple line, more than 7 millimeter, and the blood flow is very good going up to zone 4, and you do not transfer those embryos, that is not going to give you a pregnancy if there are bad quality embryos. So this is how you can streamline your patients. Damayanti from Jharkhand, rectification process. Now, how do you rectify any mistakes is only by going back, looking at them, and analyzing what mistakes you have been, common errors you have done, and next cycle, whenever you take, don't repeat those things. Like first cycle, you must have seen letrose was given. Again, the second cycle, letrose step up dose was being given. So I think this is the way you should rectify. So audit yourself. Auditing yourself is very important. Dr. Pramod Bodh, he is asking if TSH will increase in the menstrual cycle time, what type effect will be on pregnancy and conceiving that time? So if a TSH is increased, TSH is a thyroid stimulating hormone. When it is high and she becomes pregnant, She has likely because the fetus doesn't have the thyroid hormones at all, and it is likely to affect her neuroendocrine, and the defects would be very obviously seen if the thyroid level is high and it is undetected. But if you detect and timely give the medicines and thyroxine, you can give L-troxine, and you can give Thyronorm to these patients. They probably will immediately get corrected, and you don't have to worry about the pregnancy out uh, means pregnancy bad outcome. Sachin Shah, for luteal support, what are your criteria regarding the doses preferred route of administration? For luteal support, I need to see the endometrium first. My endometrium should be more than 7 millimeter, and the zone 2 should be more than 2 millimeter. If that is fine, then I will give only progesterone to these patients. If my endometrium is thin, less than 2 millimeter, and it's a patchy endometrium, I will add the estrogen, especially when the patient is more than 35 years of age. 2 milligram once a day will be added to this patient along with the progesterone. My preferred route of administration for progesterone is oral, and that is a dydrogesterone. Lotus 2 trial, I was the principal investigator and author. And after that study, I realized that I think this is the only progesterone which works best. So we prefer oral progesterone, but if economically it is not viable, you can still use a micronized progesterone capsule, which to be inserted but not orally. The This is the way, and give for the luteal support for 15 days. I sometimes prefer even giving HCG to these patients. Whenever you feel that the patient has to be upregulated, upregulation of the LH receptor is required. That means their corpus luteum is not very good. These patients we prefer to give HCG also in the luteal support. So this is how we deal with the luteal support. Manjula from Chennai, can you? Hi Manjula, this is a very good. Can you arrange more cryopreservation topics? I think we will talk to IFS and we will just see whether we can add the cryopreservation topics, and the embryologist will be the right person to give you the insight for the cryopreservation. I will definitely talk to Dr. Sudha Prasad and Dr. Neena Malhotra. I have same type of patient, last case you described. At present, she is 34, 35 K with persistent ovarian cyst around 5 to 6 centimeter. What is your advice and the management protocol? Now, if the patient is 34, 35 years and a persistent cyst formation is there, first look at her AMH. Anti-Mullerian hormone testing is very important. Most probably, this patient has a low ovarian reserve. And once it is a low ovarian reserve, probably you need to step up immediately for IVF. Don't hesitate to go for IVF. Even if she gets 4 or 5 eggs only, she is likely to get better pregnancy rate. So switch over to IVF as early as possible. Sujata from Mumbai, sperm on microtesse versus sperm abstained by TESA. So, Sujata, I'm not the right person to talk about this. This is actually embryologist question, but still, uh, according to me, sperm on microtesse is a better choice. Sperm abstained by TESA, I don't think, but microtesse is the best choice for this patient. Bushra Khan, uh, your views on dual stimulation. I think Bushra, hi. Your views on dual stimulation for IVF. Yes, we do. Whenever a patient has a low ovarian reserve, like zero point 0.7 or zero point 0.8 or zero point 0.9 AMH, we want maximum eggs to be retrieved. And when we want maximum eggs to be retrieved, in the same cycle, we give a twice double stimulation for this patient. We start day. Oh, okay, okay. She is 35 weeks pregnancy at present with ovarian cyst. Oh, 35 weeks pregnancy it is. Oh, not to worry, not to worry at all. Leave that ovarian cyst as it is. You just don't do anything. Only as she delivers, because she's 35 weeks now, 36 weeks you deliver her, and once you deliver, but don't try to take out that cyst because it's a persistent cyst. Do her CA-125, look at her INIB, all the markers, and then accordingly you take a call for her ovarian cyst removal, because sometimes after pregnancy or delivery they may regress also. Coming to Dr. Bushra's, so we start with dual stimulation on day 1 or day 2. You start the gonadotropins. We keep giving the gonadotropins till the follicle size goes to 18, 19 millimeter. We give injection GnRH agonist for a trigger. Never give HCG injection because it remains 7 days later on in the cycle or in the body. So give agonist trigger, and 36 hours you do the stimulate ovum pickup, retrieve the eggs, and in 48 hours immediately again you start the stimulation, and that again goes up to 18 to 19 millimeter follicle, and again give the trigger. Here you can give HCG trigger, doesn't matter, because we do not do any embryo transfer in this cycle. Only double stimulation or dual stimulation aim is to get more number of eggs. So we definitely do that, and this is the way it should be done. Now, Rachita Wala, she is from Sonpat. Madam, please tell step up protocol of letrozine. Yeah, this is a very good question, and this is very useful whenever you feel that you need more than one follicle, Richita. If you want follicle 2 or 3 follicles, opt patients protocol is a letrozole step up protocol. Day 3 you give 2.5 milligram. Day 4 you give 5 milligram. Day 5 you give 7.5 milligram, and day 6 you give 10 milligram. So you step up every time, you step up one dose, and you see that you will get 2 or 3 follicles, very good follicles, and a very good endometrium also, unless patient has a hypoestrogenic. Otherwise patient will respond very well, and you can do IUI accordingly. So this is a step up protocol with letrozole. I think same, she's asked questions. So with this, I think we have a time up now. Tejas, I think we have answered all the questions.
Yes, ma'am. I think we have done with all the questions. So,
Yeah,
ma'am, I'll request you for a short takeaway message for the doctors.
yeah. So the take-home message is infertility is a very crucial time-bound management. So one has to understand that we are not going to waste her time, and your stimulation protocol has to be designed, thought over properly. You need to look at her endocrines. Endocrine profile will be very, you can say, a guideline or a roadmap for the infertility management. So hormonal profile interpretation is extremely important in these patients, and don't put all PCOS in one basket. According to the phenotype, you start dividing them into category 1, 2, and 3, 4, as I showed. And then your stimulation protocol has to be depending on which type of a phenotype the patient is being presented to you, and start treating her. If a patient has an endometriosis, even if it is less than 3 centimeter, but the patient is not getting pregnancy, you think about laparoscopy, hysteroscopy, you will understand that her endometriosis clearing would give a better pregnancy rate. And timely referral to IVF, or in time doing IVF, is very, very crucial. Whenever a patient is going on ovulation studies 10 times, 15 times, 20 times, please ask your sonologist how they have been writing MSF when there is no follicle at all. Or sometimes there is a multiple small follicle and people write no follicle. So ask them whether the follicles are seen or whether they are not seen, and how many follicles are there, antral follicles especially. So this is all. All the very best. and infertility is really enjoying, and it is improving also. It's like detective. You keep on understanding the patient more details if you go on details in your own practice with the case studies, and you will find the answer one day. And if you have any questions, or personally if you want to ask, I my number you can reach on me 9822043112, or you can ask DocMode people. They will give my email ID. You can email me, so I'm available. And be member of Indian Fertility Society. It's a very excellent academic society, so be member. If you are not member, we do lot many academic programs with Indian Fertility Society. Uh, we welcome you for that. And thank you very much.